All right. I think we could go ahead and get started. Hello and welcome everyone to Women's Health Tech Wednesdays. My name is Nina Joshi, and with us today we have April Smith-Hirak, the Regional Health Administrator for the U.S. Department of Health and Human Services. Before we jump into the conversation, just wanted to give a quick background on myself. I work as a consultant and design researcher at Kaiser Permanente's Innovation Shop, where I design and deploy digital health solutions. Before we began our conversation, just had a few very quick announcements. The first one is that the Women's Health Tech Challenge applications have been extended to October 22nd. More information on that and the link will be available in the chat. We also have two studies that are going on through HITLAB. The first one is for treatment for breast cancer, and the second one is for postpartum. So if you're interested in participating, please also, all of that information will be in the chat. And then the last thing is tomorrow we have the Digital Health and Human Rights Symposium. And if you're interested, the information to register will also be available in the chat area. And I think that's it for announcements. And so with that, I will warmly introduce our amazing guest, April. April, thank you so much for being here and welcome.
Thanks, Nina. Thanks for having me. It's exciting to be here.
Yeah, of course. Well, maybe to start things off, if you could tell our audience a little bit more about yourself and, in terms of your background and really the journey that led you here.
Sure. Well, I actually have a very strange background for somebody who is in public health in the federal government. My PhD is actually in psychology. And
wow.
I entered in psychology in the cognitive area, and so we had that proverbial black box where AI kind of sits. Where how do you create intelligent life? What is it that makes us actually tick? And quickly moved from there actually to social psychology, and social and health became the intersection of all of my research, which is how I ended up as a behavioral health scientist when I joined the federal government, right about a year after my PhD. So I entered with a small program called the 5-A-Day program, which encouraged people to eat lots of fruits and vegetables, and worked on the rebranding of that from a behavioral health perspective to the More Matters program, which you can still see if you go to the grocery store on what are now acknowledged to be evil plastic bags. But the produce bags that you see, you'll see like a little More Matters sign. So it's kind of fun to kind of see that perpetuated. Not in plastic, but the program itself being perpetuated. And from there, I spent a lot of time at CDC in an emerging leaders, so a leadership rotation program. So I got to really experience all the best of CDC, which was where I discovered my love of policy and innovation and partnerships, and the power of bringing people together to solve really hard problems. So I worked at CDC for several years. My last position at CDC was infectious disease issues management, so short-term policy, and also managing the regulatory agenda. So I kind of did super long-term and super short-term policy. And then from there, I left and came to a regional office. And when I moved over to the Office of the Assistant Secretary for Health, our function is really to represent in our region, and there are 10 regions across the country, the interests of the Federal Department of Health, the Assistant Secretary for Health, the Surgeon General, and the Secretary of Health. And so we are very much policy implementation and delivery, which is kind of my sweet spot. And what's really nice is that we get to take a bit of a broader view, and we're able to be the senior public health experts in the region. So we're relied upon for some ground truthing and information so that the Beltway itself doesn't become so insular that they're not aware of what's going on in the country. So we also have a really great function to communicate priorities and emerging issues back and forth to headquarters, which is kind of fun. And I've been in the regional office now for 12 years. So
wow.
It's been a while.
Yeah.
We cover a really great region. We have Puerto Rico, the U.S. Virgin Islands, and New York and New Jersey. So it's very diverse, both geographically and culturally.
That's incredible. It seems like you kind of get to have a good mix of high level strategy and then the boots on the ground implementation, and really making sure that the communities are kind of aware of what's going on.
Yeah, we work a lot with states and with communities, stakeholder organizations. We do a lot of convening. We kind of try to link the right people together to create action. So it's very exciting for us to be able to start thinking in new and innovative ways. And our
Absolutely.
office, also the Office of the Assistant Secretary for Health, houses several program offices, including our Office of Minority Health and our Office
Oh,
of
wow.
Women's Health. So we represent
Hmm.
that in the region as well. So women's health is a big part of our portfolio, and we're really, really excited to be able to kind
That's
of talk
incredible.
about what happens when you build innovation with women in mind and with women's health in
Right.
mind, and how do you create a system that is more equitable and really represents women. So I think a lot of the people who are probably watching today are kind of my heroes for doing the really hard work and bringing a lot of equity to women's health.
That's incredible, and an incredible segue. Really would love to learn a little bit more about kind of the, what role or how large of a role does women's healthcare play kind of when it comes to implementing health policy, and what specific areas are kind of you seeing when you really look at women's health kind of as from a landscape perspective of areas that kind of need more attention, especially, now in a post-COVID world.
Well, I think, COVID highlighted a lot of things for us, but some of the systemic issues that we have with health and healthcare, they go all the way back to what we would consider modern healthcare, right? So
Yeah.
healthcare itself has always been designed for men, like the design for drug and all sorts of other platforms was men. They were the ones who were
Hmm.
studied, and for a really long time, we had this prevailing viewpoint in the medical field that women's hormones just mess everything up, so you can't use them to study. It's kind of like I'm a
Yeah.
lefty, and I volunteered to be in MRI studies when I was in graduate school because I was like, let me help my fellow colleagues out, and they were like, we don't
Yeah.
want you. You're lefty. Your brain is messed up. So I think that's a joking issue, but it's the same type of thing. Like if we don't incorporate the the women's perspective and the fact that we do have different hormones and things like that into our medical
Hmm.
research, then we end up designing drugs that really work differently in women and in men. And I think that recent research where we're looking at those disparities from like a very technical medical health perspective, we are seeing that
Right.
there are drugs that work completely differently in women than they do in men. And so designing a system that really works for women, and this is absent all of the cultural issues that continue to perpetuate differences in health status, but
Yeah.
really for women sometimes it is an uphill battle to be engaging in a healthcare system that really was not necessarily built with them in mind. And I think we've come a really long way. We do a much better job than say in the 1950s, right?
Yeah.
When we do all of our clinical trials today, the clinical trials always include women of different ages, women of different statuses, meaning pregnant, non-pregnant, menopausal, premenopausal. And so I think we're doing much better with understanding those differences. And I think our medical knowledge is also just advanced. But
Hmm.
from, a sheer public health perspective, just even things like when you're looking at heart attacks and the fact that women experience heart attack symptoms differently than men do, and many people
Mm-hmm.
do not know that. So
Yeah.
where women might expect that if they were having a heart attack they'd be like clutching their chest and in pain, it doesn't always happen that way. Sometimes they get
Right.
nauseous, and sometimes they get dizzy or break out into a sweat, and that might be your only symptom.
Yeah.
So you may not get that traditional like, oh my god, my heart is like is burning in pain.
Hmm.
Might feel like there's an elephant sitting on your chest. That could also be a symptom of a heart attack. And I think that sharing that there are those differences is something that we continually strive to do better, and to educate
Right.
women, to make it possible for women to be the best advocates for themselves and to access the care that they need.
Yeah, that's incredible. And I think something that you said, really resonated in the sense that, with everything that's been going on, all it really did was just shine a light on an existing problem. It didn't necessarily cause that problem. It was there before, but now, there's finally the eyeballs on it. I think that we need to really kind of recognize that change needs to happen.
Yeah.
So I think that's a really good call out. Incredible. And so also, kind of on the vein of women's health initiatives, what are some of the projects that your team, your administration is kind of working on to kind of support women and really drive forward for women's health?
Well, we're really interested right now in a few different topic areas. We're very much focused on hypertension and having
Mm,
women understand blood pressure control. We know that much more of the country than is diagnosed as hypertensive, and it's a real risk factor for strokes and for other conditions. We also know that diabetes and hypertension often go hand in hand, and some other disease states. So we often think about what we call multiple chronic conditions, where you have one and it either leads to or piles on top of another and another and another, which leads to a worsening health status. So hypertension is one that we've definitely been looking at and trying to educate women about how to manage blood pressure. And also just to understand like what's important with blood pressure. Why is it important? The other area that we've been really focusing on is maternal mortality and morbidity. We have incredible health disparities in this country with maternal outcomes. And there is no reason based on the color of anyone's skin that any woman should have a worse outcome than any other. So we are constantly looking for best practices and new modalities to improve the outcomes for pregnant women and their newborns. It's something that is not an easy answer, but it's something that we really feel passionately about and continue to work on. We're also working really hard on increasing the sustainability of community health workers. Community health worker might be somebody that you know and trust from your neighborhood and is educated in like diabetes prevention or whatever the disease state is, or who might educate you about your COVID vaccine. Like you have questions about it and they're trained to be able to answer that. And in some communities, particularly in Latinx communities, they're often referred to as promotoras. So they're like women who promote health. And women are often kind of the backbone of those CHW networks. And it's so important that the women that we have as role models that we trust in our communities are able and empowered and can in many cases be paid to fulfill that gap and to really get the support that they need and the training that they need to be able to be that key person in their neighborhood or in their community that can make that difference. So we've been looking at that as well.
Wow, I think that's incredible. I think being able to have those pillars in the community that the community can already kind of go to and trust, and really making sure that they are trained up and educated. I think that is such an incredible initiative. That's amazing. So now kind of wanted to ask you a little bit, kind of pivoting, away a little bit more from the Women's Health Projects, but really kind of talking about policy in general. I think something that I'm just very curious about, I think as we are starting to see, this emergence of all of these innovative, healthcare technologies and tools, remote monitoring, there's just so much that's going on. What do you see as kind of the relationship between all of these emerging technologies and health policies? Like what does that look like, and how do we use them together to reach our healthcare goals?
Well, I think from the standpoint of this administration, we absolutely promote policies that support women's health, that support women, that support equity in healthcare and healthcare delivery. And so these things are priorities for us. The government policy landscape is kind of there's guidance that can change and be changed fairly quickly. And I think we saw that with COVID-19, right? Like we came out, we said, don't wear masks. And then we came out and said, wait, the science says wear masks. And so I know that can often be very confusing. And that's a good illustration of why you don't want everything to be guidance. You do want to have some of these other policies that are much longer term and much more difficult to change. So we get policymaking in a few different ways. We get that kind of guidance that is really under the purview of different agencies or within our department often. And then we have, that statute-based policy where Congress says, we're creating a law that says you should do this, and like the ACA was actually statute-based for much of it, and then often those statutes delegate some responsibility also to the federal department to create regulations. The tricky thing about regulatory policy is that it has the power of law, but it doesn't have the representation of law. So we create regulatory policy, and we have a very, very long process to go through to create or change a regulation. So I worked on, when I was back at CDC, the fastest regulatory policy that I had worked on was the interim final rule that lifted the ban on HIV positive travelers to the US. And that across 2 administrations, and it was 18 months in the making from start to finish. And that was fast. That was like warp speed fast. Usually what happens is the lock-making process is considerably longer, and it can be a matter of years. So for 3 years before I left CDC, I worked on international and domestic quarantine policy. And the update to the regulation was not that substantial, but it was providing a due process within the context of quarantine for anybody who was under quarantine, which had been missing from the regulation. And in order to get that through, it actually took until after I left. It took 5 years start to finish for that policy. So policy can be something that shifts really quickly, like a guidance, and it can be something that takes like 5 years, like some really difficult, tricky regulations. And there are a number of bars with regulatory policy that have to be crossed. So we have to go through the Office of Management and Budget for any regulation that is going to have more than $100 million impact. And we have to be able to say what the impact is economically on the government and on the country. So how much is people's time worth? How much of an impact would this change have? And then we ask for comments. So we ask for public comment, we integrate comments. And then we publish a final rule, and the final rule then has, depending on what the rule is and how it's written, there could be anywhere between a 30 and 90-day congressional review. So Congress can then repeal that regulation. And what that does is it protects the American people, right?
Yeah.
So there's your civics lesson.
No, I love it. This is good.
Many of the things that we work on that would enable innovation, some of it can be changed with like a quick interim final rule process or a quick guidance change. There are other things that we would need to spur innovation to help to promote the innovation that's happening now that require regulatory change. And I think that the source of frustration probably from many of the stakeholders who might be watching today is like, I need that regulation changed, I can't work with it. And these regulations are often not written with current technology in mind. Sometimes they're 10, 15, 20, 30 years old. And so it's very hard to work within the context of that regulation. And it's also not that easy to change it. And so the waiting part for changing a regulation is difficult. But on the other hand, you don't want the scenario where like we get more scientific data, or we go a little further down that path of innovation and we realize what we thought was really important at the beginning isn't, and now we have to go and change it. So we want to be able to provide, as a government, we want to be able to provide that consistency for the regulation and the regulatory policy. So, that's a little bit tricky sometimes to work with innovation.
Yeah, absolutely. No, it's interesting. You really did outline a great process, and really kind of how that balancing really needs to happen between things that are new, but also, within existing structures that were kind of meant, like you were saying, with the American people in mind. That's incredible. Thank you for that. I learned a lot.
It's kind of hard. Like you want to protect the interest of the public. We're there to protect the health and interests of the public, but it also sometimes can make it harder for innovation to happen. And so it takes a lot of creativity on the part of people in the government and on the part of the innovators to figure out the best ways forward. And I think when we do it right, it works beautifully, right? Like innovation happens and we change appropriately, but not so fast that we're following a trend that will lead us down a negative path.
Absolutely. I like that. Sometimes some out of the box thinking is definitely warranted. And it seems like this is the scenario. Yeah. That's incredible. I know earlier you were mentioning, you do a lot of work with women's health as well as with minorities. And I think when we kind of think about those two together, would love to learn a little bit more about what, the Department of Health and Human Services is doing to really tackle these issues when it comes to health inequities.
Well, I think a lot of it boils down to some data. We've been really looking at data a little bit differently, and we are incorporating what we like to call the social vulnerability index or social determinants of health. So we understand that it takes much more than healthcare to provide a full picture of an individual's health and health status. And so sometimes that could be something in their community? Is their community safe? Is their community walkable? Do we have environmental justice issues in the community? Are they drinking out of lead pipes? Are they, there's just a million different factors that can kind of go into an outcome health-wise for somebody.
Yeah.
So what we try to do is we've been integrating a lot of that data and looking at layered data and trying to understand communities that are most socially vulnerable. So communities where there is disproportionate economic disadvantage, where there's less access to education, where there's, poor access to clean air or water. Or so we start looking at all of those. And when we look at that social vulnerability index, we're able to kind of target our interventions so that they're more appropriately based, so that we are also bringing in solutions that are not only health-based. Sometimes the health care, you're treating just the symptom and not the root of the problem. And that seems to expand even beyond just health conditions. It expands into like a general wellness. And so we've been taking a much broader look at that and working with some partners that we think are kind of non-traditional partners. But we think it's important to be able to address disparities and inequities. In order to do that, you have to understand what the root causes of those are.
Absolutely. Absolutely. Yeah, I really like that holistic view and kind of thinking about it, not so much even as healthcare, but people care and really about, all of those other factors of just, an environment. So I think that's incredible. Well, I think you have such a good position, where you are and really being able to kind of see what's going on. What are some of the the trends that you're seeing, or what is the direction that you would like to see, women's health take in the coming years?
Well, I know that this is Women's Health Tech Wednesdays, so I'll kind of address that because I'm a little bit of a technophile. And one of the things I like to think about, and I think that we can do better at thinking about, is in public health, traditional public health, we tend to solve tomorrow's problems with today's tools. And we don't always have the imagination to look forward and say, what are the tools that are going to be applicable to that problem that we're trying to solve for tomorrow? And for me, it's really important that as our innovators who hopefully are listening in or watching in, as they're looking at their tech solutions, building that equity, building systems that support women's health from the ground up. We should really learn from the legacy system that we have that started in the 1800s, that didn't include women's perspective, that didn't include modalities that would help us to function at our best. And we should, as we're looking at building the next generation of health and health tech, look at how do we enable and empower women to be healthy as a baseline integral part of that system. And so that's what excites me the most, is really beginning to solve those problems with the innovation that's available to us, and having that innovation be sensitive and responsive to women's health.
That is incredible. That's amazing. And I definitely, what you were saying about where we are solving tomorrow's problems with today's tools, I feel like that's something I need like on a sticker or something, because it's so true. And I think that's incredible. And then I know we're almost at the end, but one of the last few questions I had was really around, the role that you play, and what advice would you have for other folks that are looking to kind of get into public health and have a passion for women's health as well?
I think public health is a field that people only go into if they're passionate about it. It doesn't pay really great. There's not a lot of glory. We don't often get recognized for the work that we do, but that's not, we don't do it for the recognition. And I think that there are a lot of ways to be involved in public health and women's health that are not, governmental. There are wonderful nonprofits. There are amazing companies that are coming up. And I think that it takes all of us to be public health proponents. Public health is about community-based health, like the population's health. So the healthier we all are, the better our population health is. And that's really what public health is all about. So, getting into public health, I think, is not that hard. It's just you have to really want it. And, you have to be passionate about it, and you can be that public health person from anywhere inside that ecosystem. It doesn't have to be governmental, but if you are interested in governmental public health, certainly folks should reach out to me. I'm always happy to have a chat.
I love that. No, I love that approach to how, it starts at any time from anywhere, I think, as long as there's someone that is passionate and really willing to kind of be that voice. I think that's really beautiful. Right, incredible. Well, thank you so much, April, for an amazing conversation and honestly a really great lesson in civics for me. I think that in and of itself was really informative. Really, really appreciate you taking the time to chat with us today. I know you'll also be chatting with everyone tomorrow, so also really excited. And for those listening, if you want a part 2 of April's conversation, please be sure to check that out tomorrow. Just in terms of announcements, next week we have our next Women's Health Tech Wednesday guest, Meg Columbia Walsh from AWS. So please tune in to see that. And then just as a final reminder for those, we also are in the process of recruiting for 2 separate studies, one for breast cancer, one for postpartum. So if you are interested, all of the information is in the chat. Also wanted to let everyone know that the deadline is extended for our Women's Health Tech Challenge to the 22nd. Also, the link to apply is in the chat. And then if you want to see April and folks tomorrow, make sure to check out the Digital Health and Human Rights Symposium tomorrow at 11 a.m. And with that, on all of the information, if I spoke very fast, you weren't able to get all of that down, please be sure to check us out on social media to get the updates on what's going on with HITLAB. And then just wanted to say thank you again, April, for an amazing conversation. I'm really looking forward to hearing what you have to share tomorrow.
Thanks so much, Nina.
Thanks. And also quickly wanted to say thank you to our sponsors, Goodwin and Witham, for sponsoring this amazing conversation. Thank you so much, April, and have a incredible day, everyone. Thank you.
Bye.